Welcome, everybody, to the Kona Shane Veterinary Podcast. I am your host, Dr. Andy Roark. Guys, I got a great one for you with my good friend, Dr. David Dycus. Dr. Dycus is an orthopedic veterinary surgeon, and if you haven't heard him on the podcast before, you've been missing out. He is just a fantastic resource on all things orthopedics. And today we're talking about hip dysplasia. Guys, we see hip dysplasia, we wrestle with hip dysplasia. I wanted a very fast download on the surgical options for hip dysplasia and when they're appropriate, meaning when in the lifespan of the dog, and what they entail, and just get me up to speed on our surgical options here, Dr. Dycus. And he did, and it was great. And it's not what I was taught in vet school 15 years ago. There has been a number of advancements. I think, of course there has. That's great. But it is really good. He makes a lot of points and I go, oh yeah, that totally makes sense. Anyway, this was a fantastic conversation. This is going to affect how I talk about hip dysplasia in the exam room. I hope it'll make that impact for you as well. Let's get into it.
This is your show. We're glad you're here. We want to help you in your veterinary career. Welcome to the Cone of Shame with Dr. Andy Roark.
Welcome back to the podcast, Dr. David Dycus. How are you, my friend?
Oh, I'm fantastic. Thanks for having me back again.
Man, it is always my pleasure. I so enjoy having you in the podcast and getting to talk to you and learn from you. You are a very, very smart guy. You're also a very, very busy guy. You are, for those who don't know, you are a lecturer. I've seen you lecture all over the place. You write a ton. You are also the founder and owner of OrthoVet Consulting. And because you don't have enough going on, your new venture is a surgery specialty hospital outside of Washington, D.C. It is Fusion Veterinary Orthopedics, which, when are you set to open?
Hopefully, we're going to be opening in mid-October of 2024. So not far. Things are moving quick.
You are right there, just staring at the finish line from where we are. I appreciate the heck out of you being here. One of the things that I always like to talk to you about when we get together and we've got sort of orthopedics on the table, I always like to keep this thing super practical, and I want to keep growing my own skills in the exam room and making sure that I'm giving pet owners the advice that's going to help them. And I have had a string recently of hip dysplasia cases. I have got a couple variants. I've got the German Shepherd puppy that's vocalizing when I stretch his hips out, which maybe it's just behavior. Maybe he's just tired of being handled, but I'm concerned. And then I've got obviously the older dogs that are having a lot of hip dysplasia. They're just very minimal muscle mass in the back end and sort of everything in between. And so I'm looking at these patients. I'm thinking about what we can do for them. And today, what I really wanted to do was get a rundown with you of hip dysplasia surgery options. What are my options for trying to surgically intervene in these hip dysplasia cases? And then also, when is it appropriate? Because I know that there are some cases that we say earlier in life is I would probably go for this, and later in life, we're going to go for that. And so I was wondering if you could help me just as an overview. What are my options for surgery, and when would I put these options into play?
Great questions. And a lot of it is going to depend on the age of the dog, the clinical signs they're having, the breed. And so what I like to think about is if we're going to think surgery, we're going to put them in the category of potentially hip joint improvement in terms of the anatomy, versus moving more towards a salvage option, which would be doing something more definitive to the actual joint itself. And what I mean by that is we can take the improvement in the hip joint category, and there's usually two surgical procedures that we would put into that category. One is what's called a JPS, and we all call it a JPS because it stands for juvenile pubic symphysiodesis. So it's just easier to say JPS.
Got it.
And then the other would be either a triple or double pelvic osteotomy.
Okay.
And so the reasoning age comes into play and breed is the cutoff points for these two procedures are very, very different. So with a JPS, and the whole theory here is with hip dysplasia, there's laxity of the hip joint. So when the animal is trying to walk, and when the leg is in the air, the femoral head is subluxating from the acetabulum. And then when the foot strikes the ground, it causes the femoral head to crash back into the acetabulum. And that creates abnormal wear and tear on the cartilage, which we all know will lead to arthritic changes. And so in dogs with hip laxity that are very, very young, we can do things to try to improve the coverage of the femoral head into the acetabulum. And so a JPS would come into play in dogs at around 16 weeks of age. One has to have a very high suspicion of a dog with hip dysplasia at 4 months of age, because these are usually still bouncing, happy go puppies.
Yeah.
And so in these situations, we usually look more towards breeds that tend to be predisposed. So we think German Shepherds, we think Rottweilers, we think Labradors, we think Golden Retrievers, Newfoundlands. And in these dogs, if they come from a line that has dogs that have previously had hip dysplasia, or perhaps there's poor breeding practices, somebody says, hey, I've got this beautiful German Shepherd. Somebody in the Walmart parking lot was selling puppies and we picked one up. What do you think? To me, my bells are going off. There's probably some backyard breeding going on. And in that case, at JPS, we make a little incision just above the pubis. Okay. And we actually prematurely fuse the cranial part of the pubis. And when we do that, as the animal's growing, it actually pushes the acetabulum outward and over. So it actually covers over the femoral head as they're developing. Mm-hmm. But if we wait until after, say, 18 weeks of age, then the degree of coverage there isn't going to be enough to really help us. And the whole goal is to try to improve the coverage to minimize changes to the cartilage and thus minimize arthritic changes in life. And if one is astute enough, they could do an exam in a puppy, and every puppy's squirmy. So you try to extend their hips, and every puppy's going to squirm like it's bothersome to them. But the reality is, many a times they're just not used to being held that way. So what I would recommend an individual do would be to check what's called an ortolani, which is a test to check for laxity of the hips. And that's done by basically putting a hand sort of on the dorsum of the dog, mm-hmm. and then taking the other hand at the knee, and you sort of push up on the femur, and then that will cause the femoral head to subluxate. And then you start to pull the leg away a little bit, and that would cause the catastrophic reduction. So you're listening for a thud or a click.
A thud as
or
it pops back in?
Yep, exactly.
Okay. How does the dog react to this?
So in some situations, if the hips are really lax, they usually don't even react at all. Okay. The challenge, though, is if there's mild laxity, they could have some muscle strength that could prevent you from being able to get a positive ortolani when they're awake. And so in a otherwise healthy dog that's there for, say, a routine vaccine visit, I'm going to look at the breed of the dog. I'm going to do a quick ortolani. And if it's negative and the breeding of the dog has been very, very good, meaning that it comes from a reputable breeder and all the due diligence has been done, then we might not jump to saying, okay, let's sedate just to make sure we don't get an ortolani. But if I have a dog that we're just not sure about the breeding principles, or I'm not sure if I'm getting an ortolani, or there's a little bit of discomfort on hip extension, then I might say, okay, it might be worth doing a quick sedation just to check for hip laxity and at the same time get hip x-rays. And we want to get well-positioned hip x-rays, but we have to remember that when we do that, we put them on their back, we pull their legs down, and that actually forces the femoral head into the acetabulum. So if there's mild laxity there, you might miss it. Yeah. And so one of the cool things that people can do, and I think the training is free, is become pin hip certified.
Okay.
And if you're pin hip certified, what you could do is take the pin hip radiographs, and that gives us what's called a distraction index, which tells us the degree of laxity. And if that distraction index is above say 0.3 or is on the upper end for that particular breed, then you could do a JPS. You could say, okay, we've got a German Shepherd. We believe breeding was good, but when I was manipulating their hips, they were a little more squirmy than I thought they should be on hip extension. Or I was trying to do an ortolani and I thought I got it, but the dog was also a little bit reactive, which I wouldn't have expected them to be. So we talked to the owner about sedating. We check ortolani when they're sedated. We get our well-positioned hip radiographs, and then we do a pin hip. And if the pin hip number is higher than it should be, we can say, okay, we need to do a JPS. And for that to take place, we really have to start this thought process of looking into these dogs when they're very young.
Like when they're a fetus, like 3 weeks before they're born, we should start talking to the client about, okay.
So what I would say is think about when they're coming in for that, I don't know, is it 12, 13, 14 week vaccine appointment? Make that, and I think that usually correlates to when they're getting the rabies vaccine, maybe. Yeah. Well, make that visit where you check hip extension, check ortolani. Okay. And you don't have to do that in a dachshund or in a greyhound, if anybody's ever actually seen a greyhound puppy. But in a German Shepherd, in a Labrador, in a Golden Retriever, absolutely, I think it's worthwhile to check. And then the other one that would be super easy is the dog's actually having an issue. And so the owner brings them to you. He's really slow to get up, or he tries to jump on the sofa, but he can't, or he refuses. Then that obviously would warrant a more in-depth workup. But you can do some slight screening at that visit that really shouldn't take a lot of time. But if some of your little red flags go off, then it says, okay, we're not going to do this at today's visit, but let's get you in maybe next week and let's get this kind of figured out just so we can be safe.
Do you do a lot of these procedures, David? I mean, in all seriousness, it's just, I was going to say, it seems like such a specific case. When you said, hey, this pet's coming in, he's really slow to get up, he's not, his litter mates are behaving and he's not, to me, I go, okay, that would be the type of flag where I go, oh, we've got someone who's attuned to what's going on. They've got a basis for comparison to other dogs. It's terrifying, I think, to have that conversation with a 12-week-old puppy, its owner, and say, we're talking about a permanent alteration of your dog because I'm worried about what this is going to happen. And it seems like there's so much pressure to say, well, let's wait and see how it goes. And again, I'm really checking myself here. I think your idea of checking ortolani, I think that's a real pearl for me to take away and go, I think I can get into that. The reminder at that 12-week visit, I think I can see me really starting to lean into that and to really dig into that orthopedic history there. I think that makes a lot of sense. The whole thing, I'll be honest, my hands are sweating because I'm like, oh man, that recommendation, unless the owner comes to me and says, I'm concerned because of what I'm seeing, that feels like such a hard call to make of, let's go for it. That's, I don't know, I would struggle with that.
And I think you just hit the nail on the head. And you hit the nail on the head on the fact that why many of us don't do many of these procedures is because they get missed, because it's not on our radar. And we also don't want to be Debbie Downer to the clients that have a bouncing puppy.
And the puppy is often, they're squirming, they're wiggling. I'll put a puppy's hips in extension and they go, ah, and I'll go, are you doing that because it hurts? Or are you just doing that because you're tired of this guy giving you this weird petting? Yeah. And I don't know, a lot of times I have to do it a couple of times and try to interpret what's going on.
Yeah. And I think once you palpate enough puppies, you get kind of used to what's squirminess versus, wait a minute, this is a little bit more. But the way I look at it is, yes, you might have to be the deliverer of bad news, but in theory, if we could do a JPS, there may be the need to do nothing more later in life. So it's like, we could have this conversation now, or I ignore it. And then you guys come back in when the dog's 2 or 3. And now we got to start having a discussion on how we're going to manage this for life. Are we now having to be committed to something like a total hip replacement? Or, and I always think back to myself, well, gosh, if we had been more proactive, could we not even be in this boat? And it's the same way I approach the whole aspect of osteoarthritis. If we could just be more proactive at recognizing and bringing in the discussion before we get to the point of them having clinical signs, I think we can be a lot better at managing the long-term aspect of things.
Yeah, that totally makes sense. I think you're spot on. I appreciate you speaking to that. But, I remember being taught JPS in vet school, and that was always my thought was, am I ever going to have the confidence to say, let's do it. And I think your point of looking back and saying, could we have prevented this? Could we have taken action earlier? It's tough. I have got some huge news. My new card game is out. That's right. If you were a fan of the last card game that me and my team made, it was called What's on My Scrubs. You're going to love our brand new card game. It's called Dr. Know-It-All. It is a trivia game meant to be played in teams. It's a mixture of trivia and BS, and it is guaranteed to make your team laugh. All of the questions are meant to be challenging for your whole team. They are based on the difficulty level of the VTNE exam. So this is the Veterinary Technician National Examination. It is great to play with your veterinarians. It doesn't need your veterinarians. It can be toned up and down in difficulty. We have a number of different ways to play the game so that if you have a newer team or a team that is learning, we can tone the game down very quickly and make it fun and engaging and educational for them. And if you have got a bunch of vets that want to go hard in the paint, we can go hard in the paint. The game is made to turn up to that level. It's really flexible that way. It is going to be fun and your people are going to enjoy it. It is made to be played in small teams. That's the team building part. It's just like regular trivia when you go to the restaurant or the bar. And so it is perfect to be played in 5-minute bursts. You can put it at the beginning of your staff meetings just to make people laugh. You can do a couple of rounds of trivia and then get into your business. Or you can just say, hey guys, we're going to have a team meeting. We're just going to do some trivia. And then everybody's going to leave with a smile on their face. I wanted to make that for you. I had such a great time with our first game. I think this game is going to be really fantastic. I think people are going to really love it. Head over to drandyroark.com right now to learn all about it and get your copy sent to either you or your practice. Let's get back into this episode. Talk to me a little bit about the pelvic osteotomy. So if we're talking about less than 18 weeks here for the JPS, what kind of window are we looking at there?
Usually those are going to be the dogs that we didn't really pay attention to when they were 12, 13 weeks old. Mm-hmm. And then the clients start to notice an issue at 7, 8, 9, 10, 11, 12 months of age.
Okay.
And these are dogs that actually have clinical signs. A JPS is more of a prophylactic type procedure, whereas a pelvic osteotomy is you realize that there's now clinical signs, there's pain on hip manipulation, there's radiographic evidence of hip laxity, but there's no arthritic changes to the hips at this point. Then you would say, okay, sometime around that 8 to 12 month time frame, we're going to actually go in and make 2 to 3 different incisions in the pelvis, cut the bone in 2 to 3 different places, and we're actually going to physically move the pelvis so that the acetabulum rotates over the femoral head. So you're basically doing what a JPS would have done, but now the animal is at a point where a JPS wouldn't be effective. So now you have to physically cut the bone and move it and put a bone plate on there. And the challenge here, and I remember during my residency in the first few years out in practice, I would do these pelvic osteotomies. But then as I was out longer, I would see these dogs years and years later, and they would still develop pretty horrendous arthritic changes. And now the owner's like, okay, now what do we do? You know, you said we were going to do this and it should help. And yeah, it helped for X number of years, but now they've got arthritic changes. So now we're back to what we'll talk about in a moment on the salvage aspect of things. Mm-hmm. And so a lot of us from a surgeon standpoint that deal with patients with hip dysplasia, many of us don't do many pelvic osteotomies anymore because, as we'll talk about in a moment, we've got some other options available to us. But the key finding of a pelvic osteotomy is that they have to have clinical signs. So you would never do it in a dog that does not have hip pain. So you would never do it as more of a prophylactic thing like you would a JPS. And they also cannot have radiographic evidence of arthritic changes. And the challenge is most of them at that point, if you really start scrutinizing a radiograph, have arthritic changes. They're just not jumping out at you like when we think about looking at a radiograph and going, oh gosh, those hips look horrible. You know, you may glance at these and be like, oh, the hips look fine. But if you really start scrutinizing it, you'll see some changes associated with arthritic changes.
Yeah, that definitely feels like you're threading the needle. You need clinical signs, but not radiographic changes. And it feels like you're really trying to hit a certain window. Okay, so talk to me about these alternatives.
So once we've moved out of those categories, we're left with what we would consider our salvage procedures. And the two there would be a femoral head and neck ostectomy, or the so-called FHO. And then the other would be a total hip replacement. And I feel like where we can bring in those procedures could really be in the young, the middle, and the older parts of life. But there's going to be different criteria associated with that. I will say that I always, from an FHO standpoint, put that at the very end of the list, the very last thing I would ever do to a dog.
Okay.
And I feel like many a times veterinarians, dog comes in, say at the age of 1.5 or 2, and they've got hip pain, and they take an x-ray and they're like, oh, they've got hip laxity, they've got arthritic changes, let's do an FHO. I would reserve an FHO for the absolute last quality of life is absolutely suffering standpoint before I would consider it. And a total hip replacement would have to be totally out of the question.
Tell me more about that, right? Like, I'm with you. I've sort of seen the FHO higher on the list. It's something, it can be fairly cost effective for pet owners. People go, well, we can make this pain go away right now. Break that down for me a little bit more as to why it's so far down the list and the total hip has to be off the table.
Yeah. So the reasoning for that. So number one, before the advent of hip replacements in people, they would lop off your femoral head and they'd do an FHO, and it left people permanently crippled for the rest of their lives. They had that 100% of people had to walk with a cane afterwards. And in dogs, yes, there are studies that would say, hey, dogs seem to do well after an FHO, but their owner perceived versus the reality. But what I will say is after an FHO, hip extension is restricted in every single case. And hip extension is critical to limb function. Maintenance of range of motion is critical to limb function. So will it relieve the discomfort of the femoral head on the acetabulum? Yes. But what we're forgetting is that we also typically have a lot of scar tissue around the hip. And in fact, after an FHO, you're relying on scar tissue around the hip to develop. All of those things are inhibiting range of motion. And so we don't take in the soft tissue, the muscular aspect of things following an FHO and the pain associated with those soft tissues. And so the other excuse will people will say, well, it's cheaper. The actual process of doing an FHO is cheaper. But as I said, maintenance of range of motion is critical. And so for me, if I were to agree to do an FHO, I require the owners to enroll their pets into a formalized rehabilitation program that starts at about 5 days out from surgery. Because the whole goal there is they're starting to work on hip extension and getting hip extension. And I'm sure many of us have done an FHO and the little dog comes in at 2 weeks for suture removal and the leg is held in a flex position and you try to move the hip and it doesn't move. And at that point, we're so far behind the 8 ball, we'll never get normal hip extension back. But what I found is if we enroll them into a formal rehab program and we do that for up to about 12 weeks, we can get the hip extension range close to the normal range, not normal, but close to the normal range, so that we can have the best outcome as possible. But on the cost front, if you take in the cost of surgery plus the cost of rehab, when we did a price comparison, it actually came out to be $30 more expensive to do that over a total hip replacement.
And you've got 12 weeks of work, right? Like the owners have to be committed to this. It doesn't do itself.
If we're wanting to achieve what I would consider to be an appropriate outcome, keeping the pet's pain at the forefront and limb function, then yeah, absolutely. And then people will like to say, well, we're going to rely on the owners to do some stretching at home. The problem is that the owners can do that, but they're not going to be able to push the hip into extension to the amount that's needed to really improve it because they're worried about hurting their pet. Whereas the rehab therapist knows how much to push on the tissues and how to get the tissues to respond and react. Because the thing that we always forget about is we look at a radiograph and we say, okay, the disease ball's gone and now they're going to feel better. But we're not thinking about what does that feel like on the soft tissues when the animal's walking. So yes, they're out there running, but if you look at them run, they're not really extending their hip. It's just sort of along for the ride. So their actual gait and function is not normal, and they're just compensating because they likely are uncomfortable.
Yeah, that totally makes sense. All right, you broke that down really nicely. That all makes sense to me. Talk to me about the total hip now. What can we do with total hip replacements that we weren't able to do 10 years ago?
Yeah, we can put a total hip in the smallest of small dogs and cats all the way up to the largest of large dogs. And the interesting thing is years ago, we used to say, okay, we have to use a total hip at the very end point. We got to do all these things and then do a total hip replacement. And then we would take the 8-year-old German Shepherd that's had trouble for the last 4 years. We would put a total hip in them. And then all of a sudden, this dog is out in the backyard running again, going on hikes with the owner. And the owner's, this is a new dog. And so then we thought, well, why are we making them go through all of this to give them a happy hip? And it was because we thought we'll outlive their implant. We would have to come back and do it later. But we were basing those decisions on what they do in people. But people live 70, 80, 90 years. So what we've discovered is because dogs don't live 70, 80, 90 years, we could put a hip replacement in a young dog, and that hip replacement will be good for the life of the dog. And so in the way I do this is the way I look at this is if I have a 6 or 7 or 8-month-old dog come into me that's in excruciating pain. I'm sure we've all seen those. They're hunched in the back. They're extended in their hocks. They don't want to walk. You try to move the hips. They're screaming. You try to get x-rays. You can't really get x-rays. You put them under heavy anesthesia. You get x-rays. And then it just looks like the ball of the femur has never even communicated with the acetabulum. They are in opposite territories. We call those luxoid hips. So in those dogs, what I look at is saying this dog needs a total hip now. And so the youngest we've done is 6, 7 months of age. Ideally, the time frame would be like 10 to 12 months of age. But if I have a dog that is, say, 2 or 3, and we've never seen an issue, the dog has been great, and then all of a sudden comes up acutely lame, and then we take x-rays of the hips and the hips look bad, I'm probably not going to jump to a total hip replacement in that dog. Because number one, we have to remember that dogs with hip dysplasia and hip OA don't come up acutely lame. So we got to make sure they didn't tear their cruciate ligament first. But if I truly think it's the hip, then I'm going to say, okay, this dog's had hip arthritis, but now they're painful. Why are they painful? It's likely because they're in an arthritic flare-up. So I'm going to do things to get the flare-up under control. And if that's successful, then we're going to ride that wave. But if it's not successful, or they have a repeat flare-up kind of over and over and over, rather than reinventing the wheel, then we'll say, okay, we'll probably move to a hip replacement at this point. So I sort of, again, on the total hip thing, look at the breed, look at the age, look at the clinical signs, look at what's been done. And that's why if I had the 8 or 9-month-old dog with really severe hip pain, I'm not going to do a pelvic osteotomy. I'm just going to put a total hip in them, because if I do a pelvic osteotomy, they might feel good, but then there's a chance I might have to put a total hip in them when they're 4, 5, 6, 7 years of age. And it's, why do 2 surgeries when we can just do 1 surgery? And so that's sort of where my thought process has gone for the surgical aspect of things. But I really think we have to look at the patient in front of us, look at the age, look at the clinical signs, look at the radiographic findings. And then we also need to have a discussion with the owners as far as what expectations are, what are their financial means. If an owner is strapped for cash, I'm not going to say, well, let's do an FHO. I'm going to say, let's take your funds and let's do all these things from a conservative standpoint to get your pet more comfortable and improve range of motion. And then we'll keep doing these things throughout life as needed. But if we hit a point where that's not becoming effective, then we might have to say, okay, have we been able to save up over time for a total hip? Have we been able to throw some money into a savings account for that? Or are we at a point where we need to do an FHO, but rather than doing that FHO on the front end, because I don't want to cripple that dog when they're 2, rather than doing some other things to improve hip extension. Because what I will say is the young dog that comes in with the acute lameness, that's not a cruciate tear, that has hip pain, that's in an OA flare-up, we can usually get that OA flare-up under control and get them right back to doing the things that they were doing before they started limping without doing an FHO.
Yeah. David, would you be up for coming back and talking about conservative management for hip dysplasia?
Yeah, anytime. Absolutely.
So, we're going to make that happen. David, you're amazing. Thank you so much for being here and walking me through this. I've got so many notes. I came out when the total hip replacement was the last thing. It's like, oh, if all else fails, we can replace the hip. And so this is such a perspective shift. It makes tons of sense. I really appreciate it. David, where can people find you online? Where can they learn more about you and what you're up to?
Absolutely. So for those on social media, my Instagram is ortho_vet. My Facebook is Dr. David Dycus. You can check out my website at drdaviddycus.com. And then for the new hospital, Instagram and Facebook are both Fusion Vet Ortho.
Cool. David, thanks for being here. Guys, thanks for tuning in. Take care of yourselves, everybody. I'll talk to you soon.
Thank you.
And that's what I got. Thanks to Dr. David Dycus for being here. Guys, I hope you learned something. Do not worry. I got David immediately scheduled, and we knocked out the episode on managing medically hip dysplasia. And so that is going to be coming down the pipe. Stay tuned to the Cone or Shame Veterinary Podcast. I'll probably sped it out a little bit. Like, I love this stuff. I'm super excited about it. I think there's people who generally like to kind of mix things up a little bit. In the next couple of weeks, I'll drop that episode. I can go ahead and tell you right now, it's real good. If you enjoy this episode, you're going to enjoy that one, and it's coming soon. Anyway, thanks to David for being here. Guys, if this episode was good for you, if it was helpful, please leave me an honest review wherever you get your podcasts, or text it over to your friends. Make sure the other doctors get to see it. You know, we're always trying to help people. I love making stuff like this. I started this podcast so that I could continue to learn, and boy, have I gotten a lot out of it. So anyway, gang, take care of yourselves. I'll talk to you later on.